It's shining funny. Yeah. Okay. This is left ventricle, left atrium, right atrium, right ventricle. This is your mitral valve. This is your tricuspid valve. Okay. We are talking about mitral stenosis here. Normally, it is 5 centimeters square. In the mitral stenosis of rheumatic etiology, slowly the orifice starts coming down, which will take 5 to 10 years for it to come down slowly. So what happens is because of the narrowing of the mitral orifice, the LA pressure gets increased, LA pressure. And what happened? The LA starts slowly dilating and then become hypertrophy. So because of increased pressure, if it is long-standing mitral stenosis, these pressures get exerted in the pulmonary veins, which are directly in connection with the lung pulmonary arteries. So because of the back pressure, because of the constriction of the mitral valve, raised intra-atrial pressure, left atrial pressure, raised pulmonary venous congestion will cause pulmonary arterial congestion. Pulmonary arterial congestion. So you get pulmonary arterial hypertension. Pulmonary hypertension is one of the complications, the back pressure of mitral stenosis. Then when the lungs also get congested, the effect will be seen in the right ventricle because of the back pressure, because of the resistance to the right ventricular output, you get right ventricular enlargement and hypertrophy. So the first chamber that gets involved in mitral stenosis, your left atrium, then coming to the lungs, then your right ventricle. Subsequently, last stage of even the pressure, increased pressure, the right ventricle can also be seen in the right atrium. The right atrium also gets enlarged. So somebody asks you, what are the chambers that get enlarged in mitral stenosis? You should say left atrium, right ventricle, and right atrium. Never ever left ventricle will be either normal or little bit atrophied, but left ventricle is the one chamber that doesn't get enlarged. Unless there is another disease in the left ventricle, like myocardial infarction or something else, cardiomyopathy, usually, as a rule, in mitral stenosis, these are the three chambers that are involved: LA, RV, and RA. LV is not enlarged. So that is the dynamics of the pulmonary mitral stenosis. Okay. So, what are the causes? I think I have a couple of pictures. Oh no, wait for some time. Right. So, let us talk something about this mitral stenosis. Mitral stenosis, the etiology is almost always it is rheumatic, whereas other valvular lesions can occur because of other diseases also. Though congenital mitral stenosis and elderly, very old people, 70, 75-year-old people, we have calcification of the mitral valve, and they also can, if anybody is coming at 70 years, 75 years with mitral stenosis, the common etiology could be the age-related calcification, but not rheumatic, because rheumatic heart disease will occur between 30 and 40 years of age, between 25 and 40 years of age. Anybody coming very late in the life with mitral stenosis, we don't consider. Hello?
Hello. Hello. Hello.
Okay, now it is audible. Sorry. So, the fibrosis, the progressive fibrosis will slowly damage the leaflets, and slowly they also get calcified, and the leaflets become fused. The fusion of the cusp and the mitral valve apparatus gets dysfunction. So as I told, LA gets dilated, then RV, hypertrophy diabetes. So because of this, the left atrium is incapable of emptying the whole blood because of the mitral stenosis. The blood entering into the left ventricle becomes less, and your cardiac output becomes less. Cardiac output from the aorta. Therefore, patients of mitral stenosis also will come to you and complain that they are having lethargy, easy fatigability, tiredness, and weakness. So, one of the complaints of mitral stenosis patients coming to you is the easy fatigability because of the low cardiac output. The left ventricle is not receiving enough blood, so it's not able to pump enough blood outside. So cardiac output gets decreased. So what kind of murmur do you hear in mitral stenosis? Quickly, you can type. What kind of murmur do you hear? Anybody? Mid-diastolic murmur is very good. So I'll show the diagram here. See, if you want to draw the graph of the sounds, this is heart sound, first sound, second sound, first sound. The sound is very. This is first sound, second sound, first sound, second sound. The gap between first and second is called systole. Second and first is diastole. The diastole is usually longer than the systole. Always remember that. This is first sound. In mitral stenosis, because of this, the leaflets are not opening. So when the left atrium tries to compress, they try to open with a difficulty. So you will hear a loud first sound. Loud first sound. And in the diastole, you have a mid-diastolic murmur. This is how you have to draw. Somebody asks you to draw the murmur. This is a diagram of the murmur. This is MDM, mid-diastolic murmur. So sometimes because of the delay in left and right ventricle, see, the second sound is produced by the both heavy valves. So you will hear a small split. So the second sound is split because of the delay in left and right ventricular function. So this is a mid-diastolic murmur. You get small and opening snap. It's very difficult for students to appreciate all these things, but theoretically you have to know everything. You may, with difficulty, you may appreciate this mid-diastolic murmur, but this opening snap and this pre-systolic accentuation will be very difficult for you to appreciate as a student. It is there heard in phonocardiogram. If you have phonocardiogram, you can appreciate very clearly, and then you can auscultate the patient. If you auscultate many patients, you may start appreciating. So